Okay, this is going to be part 2 of our kind of textbook discussion that we usually have. We ran out of time last time, and so for this is like a no frills type deal. I don't have any fancy. You can see my PowerPoint's plain white. I don't have any fancy GIFs or funny pictures or cool titles on my slides. It's just basic, straightforward stuff. Have your book. Make sure you have that ready. I'm going to basically, it's going to be similar to what I've done in our face-to-face book conversations. Obviously, I have some slides and I have some information on there, but I will refer to the text. So make sure you have that as you go through. Highlight, take notes as you see fit. All right, let's get this party started. Let me get my face out of the PCL's way. That should help. Okay, so this is where we left off. We left off at the PCL sprain, and this is page 663. As you see, the two things under pathomechanics right away. I just want to make mention that it's the strongest knee ligament, posterior tibial translation. As you get into the rest of that, or the injury mechanism, it's a lot of assessment things, so I didn't really want to focus a lot on that. As you flip the page under rehab concerns, the first or the second paragraph really starts launching into the fact that this can be surgical, it can be non-surgical. Whatever route is taken is kind of controversial, because some people do well on both and some people don't do well on surgical or non-surgical, so then they go to surgical. So anyway, there's two options, and they both have some success, and so you can kind of look at that. I guess that's going to be depend on physician preference, really. As you look into the next one that we go to, did I click this right? Hold on, let me get to. There it goes. When you get to rehab progression under the non-operative rehabilitation, it starts talking a little bit about some stuff and has, the basic stuff, range of motion and that kind of stuff, pain-free. As you get down, this is on 664, second column, that third paragraph immediately starts talking about, all right, the main focus of this, quad strengthening, and really primarily closed kinetic chain exercises to minimize posterior translation. We don't want posterior translation, especially if we're doing it non-operative and we don't have a new ligament to prevent that. So that's why we want to eliminate or avoid the open chain hamstring stuff, because the hamstrings are going to pull that tibia posteriorly, and that is all on. It starts in that third paragraph, and then the bottom paragraph on 664 talks about the avoiding this. And so those are the kind of questions that I'll ask you about when we talk about, I may talk about what's the primary focus, and it's going to be quad strengthening and closed kinetic chain. What do you avoid? Hamstring, open chain hamstring. So that's kind of going to be what I want you to focus on. All right, so the biggest thing in the knee chapter that we didn't get to was patellofemoral pain syndrome. As I get to it, it's on page, looks like it's 669, got it right. So ultimately, the pathomechanics becomes a huge part of this. That's why I said it's all pathomechanics, really. And on 669, it starts talking about static and dynamic alignment. We're not going to be able to affect static alignment. If somebody has wide hips or a big hue angle just because structurally they have it, we can't affect that. What we can affect is the dynamic alignment. And so as the first part talks a little bit about static stabilizers, and then on the second column of 669 it starts talking about dynamic alignment. And then starting with Q angle and going into the next couple pages, each new paragraph, or there's a little italicized start to a paragraph, those are all the different factors that we need to worry about. And so that's what I want you guys to know, how all of these things kind of play into patellofemoral pain syndrome, and what really what really has to occur. And now as I talk about this, it kind of occurs to me, and I'm going to put my face back up here, because it kind of occurs to me that the patellofemoral pain, really in that first paragraph of the pathomechanics, patellofemoral pain is kind of this general, vague, uncomfortable pain around the patella, and it's a lot of times it's really hard to put a finger on it. But ultimately, what happens and what we're dealing with when somebody has this non-specific pain around the patella, my knee hurts, and it talks about moviegoer sign and all this kind of stuff. Ultimately, what's happening is that the patella itself, somehow the arthrokinematics of that patella sliding along the femur is altered. And so you have areas of the patella that are now being subjected to force that they're not supposed to, or they're not built to kind of take. And so that irritates, so that starts to break down some tissue, that puts strain on the tendon, that puts strain on all the different retinaculums and other structures that come in here. And that's what starts to cause some of these symptoms that are just kind of random, non-specific pain that can occur. So as I go back and get my face out of here, I'll spend a little bit of time here kind of giving you an idea of what I want you to know. So when you read this area on page 669, at the bottom of 669, it starts with Q angle, right? And you can flip the page and you read all about it. The main takeaways here is, and really the same thing in femoral rotation. The main takeaways here is what I've listed, that if we have somebody who has a dynamic Q angle increase, most of the time it's not structural, but it's from a weak hip abductors, weak internal rotators. But what that does is put them in a position, come on, computer work. I got to get my clickers to work. There it goes. So you see something like this where you ultimately, and I talked about a little bit about this with ACL and some other things in Trendelenburg's, right? We talked about gluteus medius, hip, those kind of things. But if we have these weak adductors that allow this to kind of come in here, then we get this valgus situation. The more of a valgus situation we get this thing right here. You should know what valgus vector force is and what it does. All right. And so ultimately, I'll go forward one little thing. The picture in your book, figure 2157, kind of gives you a little bit. I think this is a little bit better, but you can see this is the lateral part side of this knee. So we're looking at the left knee here. And the more valgus you get from, either hip adduction, internal rotation, whatever creates this valgus force creates a valgus vector force, meaning the quadricep pulls up the femur this way, the patellar tendon pulls on the patella down in line, in line with the tibia, and so the resulting force is this red arrow which pulls the patella to the lateral side. And so that's what the problem is. Valgus vector force always creates a lateral glide or lateral tracking of the patella. And as you know, hopefully you remember from assessment, when we talk about subluxation and luxation of patella, it primarily is going to go lateral. There's not a lot of barrier to that lateral movement. And now we're creating an environment where just the natural pull dynamically, our arthrokinematics is pulling that thing lateral. So yes, we're going to have some pain not only on our quadriceps and patellar tendon, but definitely on the patella and maybe even the femur, because it's tracking now laterally. So I spent a lot of time on this one. I'm not going to spend a lot of time on each individual one, although I have them on my slides here. But I want you to go through and kind of get an idea of that. The femoral rotation, this is kind of it's not so much a static rotation, but again, if we have muscle imbalances that cause internal femoral rotation, check out figure 2158. It's a very good picture that you can see. If it's internally rotated, that puts the patella again on that lateral tracking side. As we go through this, there's, make sure that you go for each one of these, and these three all kind of go together for me, because all of them are, again, we're pulling the patella laterally, whether it's tight here, stronger here, weaker here. So these are the kind of things and questions that I'll ask you, from somebody who has patellofemoral pain syndrome. What kind of exercises are we doing? Well, we got to stretch. If we have this, we got to stretch the IT band. We need to strengthen VMO, those kind of things. We need to really strengthen. We're not going to stretch this or anything, but we need to strengthen the VMO to make sure that strength imbalance is not as great. as we go through there. Hyperpronation, this is all of these. Make sure you have an idea of how tight hamstrings plays into patellofemoral. Well, it ultimately, you can see the steps that I've laid out, but it's all pronation problems, right? All of these lead to pronation, which leads to that valgus vector force, which leads to bing, bonk, pull it this way, pull it lateral. So make sure you have a good idea of that. The other thing the book talks about, I think this gets into, page 7. Oh, I put it on there. I didn't even see that. 763. The patellofemoral joint reaction force. That's what that stands for. And basically, it's that force that when we look at it in this plane right here, pulling the patella this way, pulling the patella this way, sucks it into that trochlear groove. And so ultimately, the backside of that patella, that articulating surface of the patella becomes compressed, and there's normal places it should become compressed, and there's other areas that we want to avoid because it puts a lot of pressure. And that's why we got the way back in the closed kinetic chain world, that when we talked about that, we definitely talked about, man, that CKC gives more surface area. Let me get that little picture up there, more surface area when we close kinetic chain to spread out the force. No, go back on the back side of that patella. So other things that the book talks about, page 673 starts talking about, again, closed kinetic chain exercises. It does talk about weak hip musculature, and it does, I want to add in the eccentric strengthening, which is definitely part of the patellar tendinopathy conversation that comes next. Speaking of which, there it is. There it is. All right, so let's go to one thing that as you flip through this, you'll see the McConnell taping. I did kind of skip over the glide, the tilt, the different, basically the patella orientation on page 671. I do want you to know kind of what those are. And there is some taping that can be done, but we're not going to go over that in this class as an intervention for that. All right, so then we get to page 683, which is the patellar tendinopathy. You should have an idea of what causes tendinopathy. That kind of stalled out inflammatory, the inflammatory process gets stalled, and this is long-term insidious onset that ultimately results in fibrosis of the tissue, because we just don't get the right collagen, that it doesn't form into the right collagen to actually repair. So if we have true tendinopathy, then the actual state of inflammation is not acute inflammation. It's this chronic inflammation. And so the book talks about, when you talk about rehab concerns, it talks about the two courses. Either we can just do our normal stuff, reduce our activity, do a bunch of ice and rest and all this kind of stuff to reduce, whatever inflammation's there. But then at some point, do we need to stimulate an inflammatory response again to kind of jumpstart that, get more fibroblastic repair, and not continue to create the mechanical trauma that caused this whole nonsense? And so, from a rehab progression standpoint, this starts on, again, 683. But there's the main things that we're going to do. Is we're going to do a lot of eccentric. Really, most tendinopathies have some form of eccentric strengthening advised, and so you can, simple closed chain. Again, we don't want to burden the patellofemoral joint any more than it has to be. Closed chain. We're going to just do basically some eccentric squats, single leg squats. You can see this is on the incline board. You may have seen this in the clinic for some of those kind of things. We want to do our jump landing to make sure we're not in that valgus situation, because that's putting stress on that valgus vector force, pulling the knee lateral. It may not be causing a problem with the patella, but now it's this torsion and this angle of the patellar tendon that's causing the problem. And then the book does talk about, on, I guess it is 684, the patellar tendon strap. They call it the tenodesis strap, but basically it's just a patellar tendon strap that we have. And really, it does talk about cortisone injection, a steroid injection, but steroid injections are to reduce inflammation, and so then you get into this debate of, well, how much inflammation is really there? Are these things necessary? All right, our final one that we're going to talk about in the knee chapter is skipping ahead to page 688. Just wanted to remind you and have an idea of what Osgood Schlatter is, especially if you're going to be with younger adolescent populations. And ultimately, you should know what an apophysis is, because this is typically classified as an apophysitis, inflammation of the apophysis. Apophysis is just a normal outgrowth of bone. So when you talk about it, this is a growing bone right here. This is the epiphysis in the epiphyseal plate where the tibia is growing, and then you have this normal outgrowth of bone that also grows. The tuberosity grows, and so this is the apophysis that becomes inflamed. Ultimately, what you have here is the growing adolescent. This epiphyseal plate grows really, really fast, and these muscles and tendons become tight and put a lot of strain on them. And you can see that tightness and that strain and stress starts to not only inflame this area, but on an x-ray you'll see that it actually starts to avulse a little bit of this patellar tendon. Complete avulsion and rupture is not common at all, and really not a concern, other than this is very painful. This is what it looks like on the outside. Eventually, this is usually treated with rest. And just allow the epiphyseal plate to close and try to stretch some of these tissues and that kind of stuff. This will heal back, but you will have this static bump that stays and does that. So Osgood Schlatter is specifically apophysitis at the tibial tuberosity, whereas the book also talks about this Larsig Johansson situation, which is at the inferior pole of the patella, which you can see here on X-ray, starting it, and then you have that kind of but you have that almost fracture right there that you can see. Okay, I'm done. I know I said this was a no frills thing, but I did give you one frill. I couldn't help myself with the GIFs. This is going to freak you out, so be ready. Ugh, watch her. Oh my gosh. I don't know if you can watch that or not, but she's going to put her hand on it and just rest on it. Look at it. Oh yeah, just chilling.